Hello, dear colleague. Welcome back. I'm happy in this evening to share with you two interesting cases. You know me, I don't like impaction. So imagine if you have a case in which it's not canine impaction, it was central incisors impaction. So the first case is Aya. Aya came to me maybe 3-4 years ago. She was 10 years old. She has a Pontic tooth between the upper right central, upper left lateral, and if you check her lateral shaft, she has dilacerated, impacted upper left central incisors. As you know, this is a challenging situation or condition. If you check the palatal view for the same patient, that bulge in the palate was at the root of the central incisors, and they kept something like a prosthetic. This is not my work, but this is her situation. In her case, I faced a challenging, let's say, impaction. This is her panoramic X-ray. She's in the mixed dentition stage, that Pontic tooth, and the upper left central incisor is pointing toward us. So this is the palatal side of the upper left central incisors. So if you check the literature about how to deal with impacted dilacerated incisors, they will tell you that you may go for surgical extraction, then later on you'll close the space or you open the space for future, let's say, prosthetic tooth or Pontic tooth. Maybe you'll go for surgical repositioning or auto-transplantation. But of course, I will not do that. So I decided why not to try some sort of forced eruption, or why not simple light traction for that central. All of you can do traction. If you check the surgery site, you are not facing the labial side of your incisor, you are facing the palatal side. This is one. Two, the root is 90 degrees dilacerated, so where you are going to end with your apex at the end of the treatment. So let's go for Aya again. So this is her intraoral photograph at the session of consultation, and this is the session of bonding. I kept that Pontic. I removed the palatal fixed retainer, and I kept that movable Pontic in her mouth. And if you notice, I added open coil spring to create space between that Pontic tooth and the upper left lateral. And in each follow-up visit, I used to add one increment of composite to get the right mesodistal width of the upper left central as Pontic tooth. And now she is ready. We have the space. So I put my 16 by 25 steel wire with a step down. That step down will act as a space maintainer. Also, it will give me the chance to do the needed, let's say, traction side. And we did the surgical exposure. So I have said, this is not the labial side, this is the palatal side for Aya. We added acid etch, and I added my gold chain. So it's very long distance. And again, it's not about traction, it's about controlling that 90 degrees bend in that tooth. Gymnastics, okay? So you need to rotate that tooth inside the bone before having the crown intraorally. Of course, so this is again the day of surgical exposure. Then after 2 weeks, it was ready for starting our traction. And if you see, very, very minimal force using elastic thread. And in each follow-up visit, I used to remove 1 or 2 coils of the gold chain. Again, this is the pattern on the palatal side of the central, and you can see with me the upper lip. So almost that tooth inside the lip. So it's not easy to control your rotation and traction. So at that stage, I took very important decision. So I shifted my pattern from the palatal side of my upper left central to the labial side. So you need to rotate that tooth inside the bone before having the full crown inside the oral cavity. And this is what's going on with the upper left central. So again, more traction, more rotation, till I get the right amount of my crown. So I bonded my retrocline torque. At that time, it was the MQ. in order to control my crown. So now we are in the rectangular wires. And finally, we have that left central inside the mouth. So it was, let's say, precise procedure. And I like the outcome for Aya. And from the palatal side, you remember the bulge of that central. This is the final intraoral photograph. And in such cases, you need to bond some sort of temporary fixed retainer in order to control your rotation. And if you have very close look at the upper left central, I can do more torquing, but again, think about the 90 degrees bend of your root. I kept that central without overcorrection. And again, this is here panoramic X-ray at the session of the consultation, and this is here panoramic X-ray at the end of the treatment. You can see with me that the root of the central is short, but remember, it is bended toward the camera now. This is here over jet photograph. So you can see with me that I shifted my traction on the labial side and the palatal side, all of that to rotate that crown inside the bone before having the tooth inside the oral cavity. So you can see with me the step. So I kept that step intentionally because I want to keep most of the root inside the bone. And this is here lateral saph. This is at the day of consultation. This is just after the surgical exposure. So this is your palatal side of the upper left central, and this is the root bulging in the palate, and this is my gold chain, and this is here upper left central. If you take a close look, so this is the crown and this is the bended root. That's why I needed not to do overcorrection, because I want to keep most of the apex in the bone, not outside the bone. So the case of Aya, and I was happy about the outcome. So consultation just before the surgery, and this is at the end of the treatment. So it was successful treatment, and for me, even if you have the dilacerated central, it's even better than any implant in the world. So she's happy with the outcome. But always you will ask about the long-term prognosis. Is it with good prognosis or not? That's why I'm happy to share with you the second case. I'm not sure if you noticed the date. So what was the date for that video on our YouTube channel? It was 2015. So again, we were talking about another case. Her name was Ala, and this is the start of her case in 2011. So the exposure is very close to Aya, the first case. But you can see with me that at that time, I was just started the passive self-ligation. So I was using conventional brackets, but with the same protocol, step down. Then acid etch, then I bonded my button. So again, it's very long distance to my main wire. By the way, she was the first case for me. Of course, you have seen that the number of views on YouTube, they were almost 3 million views for that case. So we did a traction, and again, I did the same technique. I shifted my button from the palatal side to have my bracket on the labial side, using the power chain. Again, very low force level, flexible wire. That time I didn't have the business of ligation with variable torques. I needed to do individual torquing in my TMA wire. All of that to get my root in more labial position. We finished her case. Ala, we finished her case in 3 years. So this was in 2014, and she was not a cooperative patient. Sorry, Ala, you were not cooperative. That's why we had some white lesions, but it was very successful treatment. And again, I bonded fixed retainer from lateral to lateral in her case to keep the correction stable for a while. Again, this was in 2014. She left the practice. We tried to have her in the practice. We called her, but without any response. She is gone, except the video on the YouTube channel. I wish if I had her back to the practice, see what's happening to that upper left central. Till I had that message in 2025, this year, maybe last month, from Ala. She's the same patient, and she wrote very nice, kind words. So thank you so much, Ala. She reminded me with her case, by the way. So I was not sure if she's living in Jordan or outside Jordan. So I did my best. I asked my practice, you need to call her. I need to have her in my practice. Even if she is living abroad, we can book her tickets to have her in my practice back. But we were lucky she was in Jordan, and this is the same patient. From 2014 to 2025, we are talking about 11 years of recall visits. So I was happy to have her back in my practice, and I insisted, I want to take photograph with you. And this is her old case records. She finished her degree in biomedical engineering, and she's responsible about surgical robotics, by the way. So maybe her case give her the vision or the passion how to deal with deep impacted things. So she's taking care of surgical robotics nowadays. She's very successful in her practice. And I insisted, Ala, please, I want to take records for you to make sure what's happening with upper left central. So you remember Ala from the video. So she came to the practice when she was 9 years old. That central was dilacerated and impacted. And I finished her case in 3 years. So this is her smiling photograph at the age of 12. So this is my upper left central. This is Ala after 11 years. So again, that left central in its place. She lost the upper fixed retainer, but that tooth almost is stable. You remember, always the apex will be pointing through the alveolar bone, but after 11 years, maybe I can say that you'll have normal bone remodeling around that central, because you will not see the same apex. Some of you will feel that maybe we had root resorption. We'll see the panoramic X-ray. So this is her panoramic X-ray with the upper fixed retainer in 2014. And this is her new panoramic X-ray after 11 years. So this is the root of upper left central, and again without any retention, and it is stable, and I'm sure it will stay there. So I offered her phase 3 treatment for free, because I want to keep that case under follow-up, maybe for the next 10 years, who knows. This is the intraoral photos for the same patient. So I'm happy about the outcome for Aya and Ala. So always try to use the most important talent for you as orthodontist, which is imagination. Thank you so much, and keep the good work.